Service COVID-19 Clinical Readiness and Patient Care Teleeducation Session for June 4th, 2020. My name is Sean D'Andrea. I'm the Chief Clinical Consultant for Emergency Medicine for the IHS and an emergency physician in Fort Defiance, Arizona. Today, we'll begin with welcoming remarks and a situation update from IHS headquarters provided by Dr. Jeff McCollum, the Director of the Division of Epidemiology and Disease Prevention for IHS, followed by a short COVID-19 clinical update by the Chief Clinical Consultant for for Infectious Disease, Dr. John Irilu from Gallup Indian Medical Center. And then we'll move into the focus of today's discussion, which will be critical care of the COVID-19 patient, and will be brought through a presentation provided by Dr. Anthony Massaro from Brigham and Women's Hospital Lung Center, a critical care physician there at Brigham and Women's. We'll leave plenty of time for Q&A before our closeout in the end. A couple quick reminders: please submit your questions throughout the discussion today using the Q&A feature of Zoom. Please also complete a post-session survey. This is how you'll be able to get CME credit. The survey will be, a link to the survey will be cut and pasted into the chat feature of Zoom, so please keep an eye out for that. As a reminder, the session is recorded and your attendance is consent to be recorded. Following the session, a recording will be made available for distribution. And please see the original ECHO announcement for a copy of the presenter's slides today. And with that, I will turn the call over to Dr. Jeff McCollum from IHS headquarters for a welcoming remark and situation update. Thank you, Dr. McCollum.
Great, thank you, Dr. D'Andrea, I appreciate that. And thanks for the opportunity to present to this group in this forum today. I appreciate very much everyone's time and attention to these important topics, continuing week on week. And Dr. Todt does send his regards as well as his regrets for not being able to attend today. Certainly he values participation in this forum as well as the forum itself. Hopefully he can return next week to give a personal inject to today or to next week's discussion. I'll just give a really brief situational summary and hit on some other stats and resources real quick, not to take up too much time from the other important topics that are being presented today. Just a quick national outbreak stats and summary. This is for overall US as reported by CDC. So for total tests reported, more than 19 million tests have been reported completed in the US, which equates to about 5.8% of the US population being tested if indeed each of those tests are administered to a unique person. Among those, as a confirmed positive tests are reported at 2.2 million with a national positivity rate around 11.6%. Among those, the total number of positive cases that have been reported amongst those tests is 1,827,000. And with now what we know is well over 100,000 COVID-related deaths being reported in the US. Amongst those, looking at jurisdictions and states with the greatest total case count burden, ranked from highest to lowest amongst the top 5. As we know, we've heard a lot of this in the news. New York City, New York State top the list, followed by New Jersey, Illinois, and then California. If you look at that a different way and look at the top 5 states or jurisdictions ranked by rates of COVID-related illness, it's similar but slightly different. Again, still centered in the northeastern US, New York City, New Jersey, New York State, Massachusetts, and Rhode Island top out the top 5 with the top reported rates per 100,000 persons for positive cases. Looking at IHS data regarding testing, from both federal sites as well as participating tribal and urban Indian programs. Total tests reported through 2 days ago, which is the most recent data that we have, 138,764 tests have been performed across the Indian health system, with that covers approximately 8.3% of the IHS user population having received a test, again, assuming that those tests are each individually administered to a unique patient, which is an assumption and probably not true in all cases. Amongst those, we have 11,732 confirmed positive tests that have been reported. That gives us an overall positivity rate within IHS and tribal and urban programs reporting of 9.4%. This does have a broad range. Alaska has a positivity of 0.2%. And as we know, Navajo area having being impacted significantly is at a 23.7% positivity. IHS areas with the greatest burden of reported cases, ranked from highest to lowest: Navajo tops, unfortunately Phoenix, falling behind Albuquerque, Nashville area, and Great Plains area round out the top 5. Overall reported IHS testing rate is at 84 tests per 1,000 individuals. And this does continue to exceed the overall reported US national testing rate of around 58 tests administered per 1,000 persons. I wanted to briefly mention some materials that CDC has been pushing out, not in detail, but just to again raise and consistently sustain awareness around the prolific activity among CDC for generating additional guidance documents. If you take some time every once in a while just to peek to see what's new, if you go to cdc.gov/coronavirus, if you scroll down a little bit, there's a latest updates portion of that, and you can click on view more, and it'll give you a laundry list of all the most recent updates that the CDC has posted to the coronavirus website. Not all of them be relevant to you. You can dig through and see what's useful for you. I took a quick look, and over the last week, they've had 90 updates to that site over the various components of it just in the last week. You can also sign up to receive email notifications for updates to the materials of interest on their site. So consider doing that if there's particular things you want to keep abreast of. And just encourage you to stay current on what's going on as far as COVID, in addition to attending this forum. Also, just quickly, CDC materials, their Morbidity and Mortality Weekly Update, or MMWR report, released weekly. I just wanted to mention a couple of things. There's a lot of stuff coming out. Not all of it's COVID related, but recent COVID stuff has come out. There's a recent report in the last week on the impact of COVID-19 on emergency department visits. I thought that would be of interest to this group. Basically, the quick summary is that ED visits have declined by about 42% from a period March to April of this year as compared to a similar period previous years. So we've seen that, we know that, but now we have some documentary evidence of that. There's a couple more COVID-related MMWRs published in the last week. I won't go in detail, but take a look if they're of interest to you. And finally, I just want to mention too, just some numbers that we can perhaps feel good about in all of this. In the context of these IHS Echo sessions, I want to thank the UNM Echo team for providing some statistics on attendance related to these sessions. So far we've had 11 weekly IHS dedicated Echo sessions to COVID. They started on March 17th. And over the course of the intervening 11 weeks to date, we've had a total participation of 2,526 actual live participants on the live sessions. That's an average of 230 participants per session. And additionally, for the recorded webinars, there have been 562 unique total views to those recordings, which I think is actually quite telling, because I know a lot of us have difficulty circling back and actually looking at recordings, even though we intend to. So that's roughly 20% of the live participants as far as numbers actually going back and taking a look at the recording. So I think that speaks highly to the value of these sessions. So those are some great numbers and clearly indicate the reach of these important engagements. And again, thanks to the Echo team, as well as all the presenters who have participated, and of course all of you that do attend each week are able to when you can. So with that, I'd like to thank you again all for all the hard work you do and the participation today, and for the opportunity to present. And I'll turn it back to Dr. DeAndrea.
Thank you, Dr. McCollum. And as always, thank you for the support of IHS headquarters for keeping us updated to the big picture, and for allowing these sessions, supporting these sessions each week. And with that, we're going to move to Gallup, to Dr. Jonathan Earlew, who's the Chief Clinical Consultant for Infectious Disease for IHS, to provide what has become a very eagerly anticipated weekly update on clinical care of the COVID-19 patient. Thank you, Dr. Earlew.
Thank you so much. I'm going to give a brief update. I want you to hear from my medical school classmate, Tony Massaro, who's going to give us a really great talk on critical care. But let's go through this brief update. No disclosures. Next slide, please. So what's new with prevention and transmission? There is a beautiful, huge meta-analysis put out by WHO with looking at 172 observational studies with an N combined of over 25,000. They tell us strongly that transmission is lower when you distance by greater than 1 meter compared with less than 1 meter, with a operative risk of 0.18. And if you increase the distance, the relative risk change is 2 for every extra meter. So going out to 2 meters or 6 feet would substantially drop the risk of transmission. Face masks, they strongly recommend face masks, and that primarily means the surgical masks for dropping transmission with an adjusted operative ratio of 0.15. N95s are superior to surgical masks. That's no surprise to any of us. But they also strongly recommend using eye protection, especially in the hospital settings. So this is an important change in the CDC recommendations. The CDC over the last 2 weeks has recommended that we use goggles or face shields in non-COVID units. So this might be seeing a person in the walk-in primary care clinic with an ankle fracture. It's a good idea to wear goggles or a face shield. So that's a new addition, and this meta-analysis from the WHO supports that practice. Next slide, please. So how about racial disparities? This has been a really hot topic in the literature the last couple of weeks. There's a paper by Price Haywood in the New England Journal of Medicine published on the 27th of last month, looking at about 3,500 patients at the Oceaner Health Center in New Orleans, Louisiana. And in this population, 70% of the patients were Black non-Hispanic and 29.6 were white non-Hispanic. And what they found in their population was that Black race, advanced age, high burden of illness, public insurance instead of private, residence in a low income area, and obesity were associated with increased admission odds. So the odds of admission go up with those risk factors. And what was really interesting was that 76.9% of their hospitalized patients were Black, even though only 31% of the population in that area is Black. And 70.6% of those patients who died were Black. And now Black race in their study was not independently associated with higher mortality, with a hazard ratio of only 0.89. However, a Johns Hopkins and American Community Survey that was reported in JAMA about 2 weeks ago in May showed that among Blacks, infection rate is 3 times higher and the death rate is 6 times higher compared in primarily Black counties compared with primarily white counties. So the Hopkins data actually does show an increased death rate that's significant. And Yancey was quoting a article from the Washington Post, so this is not a published paper that I'm aware of, but we're looking forward to seeing the original data. Next slide, please. Great. So how about blood clots? So Dr. Massaros, we asked him to talk a little bit about blood clots, and I did see one interesting paper by Nahum et al. That looked at prospective case series of all patients admitted to a single intensive care unit. There were 34 patients enrolled. All of them got DVT prophylaxis, and all of them had an ultrasound on admission and then repeated at 48 hours if the first one was negative. They were mostly PCR positive, 24% were PCR negative, but had typical CT appearance for COVID-19. 44% diabetic, 38% hypertension, 9% obese. And what was fascinating was almost 2/3 had a deep venous thrombosis on admission, and at 48 hours, that number went up to 79%. So this is really scary data. Let's go to the next slide. And why is that? So why is that happening? There's a really nice review article published by Levy et al. In the Lancet, dated in June. They found that persons who have COVID, a lot of them have high D-dimers, and if the D-dimer level is 1 mg per liter, the relative risk of death is increased by 18-fold. The PTs are mildly prolonged in these cases. Mild thrombocytopenia is very common, but severe thrombocytopenia, like you would see in a hantavirus patient under 100,000, is uncommon. The LDHs and ferritins are high, with the ferritin being extremely high. And then you can see those cytokines like TNF-alpha, interleukin-1, interleukin-6 might be contributing to the cytokine storm that we see. And then the pathology, when you do post-mortem exams on these patients, you find these very platelet-rich thrombi, so small thrombotic deposits in the lung and other organs. So these are not just big, huge PEs. These are microscopic, small thrombotic deposits all over the place. Next slide, please. Great. So in this review article, this review of the literature, so a lower prevalence of clot than in that other paper that I just showed you, but about a third to a half will have thromboembolic disease. So what they recommend in this review is that we follow the D-dimer, the PT, and the platelets every 2 to 3 days on hospitalized patients, give prophylactic low molecular weight heparin, and in patients who are severely ill, they may require higher doses. They said there are 4 trials in progress. I'm really anxious to hear what Dr. Massaro's practices at Brigham and Women's for these ICU patients who are really sick with COVID-19. Next slide, please. Great. A treatment update on convalescent plasma. There are 2 separate papers I wanted to go over. The first one is glowingly positive, and this is basically a review of 5 papers combining the data regarding 27 patients who received between 200 and 240 milliliters of convalescent plasma. 15 were male, 12 female, ages 28 to 75. They had, a few of them had some comorbidities, but not all of them. And all these patients got antiviral drugs in addition to CPT or convalescent plasma transfusion. They were mostly critically ill patients. 15% were on ventilators. And in these case reports that were combined, all 27 patients survived with a mortality of 0. And the only side effect reported in these 5 papers was a single red spot on the face. So these authors, given their data, say that in addition to antiviral, antimicrobial drugs, CPT could be an effective therapeutic option with promising evidence on safety, improvement of clinical symptoms, and reduced mortalities. So this is not a randomized controlled trial, and it's tantalizing, makes you interested, but let's go on to the next paper. So next slide. So this is the paper that was just published last night, which was an open label, multi-center randomized controlled trial in Wuhan, China. They had 103 patients with moderate to severe COVID illness, respiratory distress, hypoxia, shock, organ failure requiring mechanical ventilation. Half got convalescent plasma, half got standard treatment. Median age was 70. They did see a non-statistically significant clinical improvement with the convalescent plasma. And then they used as primary outcome measure either discharge from the hospital or a 2-point drop in a 6-point severity scale. And 91% with plasma got there versus 68% without to reach this primary outcome. But what was really, really notable was there was no difference at all in the 28-day mortality. So they followed these folks out a month, and they saw no benefit. And they also saw no difference in the time from randomization to discharge. So really, this paper published in JAMA just last night, which was a fairly decent randomized controlled trial, did not show any major mortality or time to discharge benefits. So I thought this was very, very useful paper to read. Next slide, please. These are simply the references that we often use in Indian country, including the Brigham and Women's COVID protocols from Dr. Massaro's group. Next slide. And I'd like to close with a picture from Nagaland. This is the first Dr. Irlu, my grandfather, who was raised in the village, went to a British Indian medical school and practiced about 50 years in the British Indian equivalent of the Indian Health Service, lived through World War II working as a doctor in the British Army, and then survived an invasion from the Indian Army in the 1950s and practiced medicine with a smile. So Grandpa has his arms crossed in front of him, kind of smiling and saying to us, COVID looks bad, but you'll be able to survive. You're going to do okay, and someday this is going to be history for us. That's all I have for today. Thank you.
Thank you, Dr. Yerlu, for that update. There's a lot of subjects there that are possibly teed up nicely for our next speaker. So it's a privilege to introduce Dr. Anthony Massaro, who's an attending physician of critical care at Brigham and Women's Hospital. They've had an extremely busy service, as I think everyone can understand. Those of us who work in rural communities are transfer and load up the tertiary care centers on a regular basis. Dr. Massaro is at a tertiary care center and has been working with COVID in the ICU there for many months now. Dr. Massaro, thank you so much for taking time out of your busy schedule to join us. It's a pleasure to have you on the ECHO session this week, and we really look forward to your update about critical care in the COVID-19 patient.
Great. Thank you very much. Whoops. Just go back. I had it sharing the screen and now I lost it. Sorry. Can you see my screen?
We can see your background. I'm not sure if Ava or anyone at Echo Central, if there's any.
No, let me try one more time here sharing.
Tony, if you click on, yeah, there you go. Perfect.
Perfect. Thank you. So thank you. It really is a privilege to be able to come here and to talk to the group, and I really sincerely appreciate the invitation. I do not have, and so what I'll be talking about, as you heard, is I'm going to be talking about the management of critically ill patients with COVID-19. I do not have any disclosures to announce. You know, we are all dealing really with this unprecedented, colossal clinical problem of dealing with a novel pathogen about which we're learning its clinical course in real time, and we don't have any, at least at the start of this, any real trial data on appropriate therapies. So it's been certainly a challenge for all of us that's unmatched in anything that we've seen before. So there's really a lot of different things we could talk about in the critical care management, because I think everything we routinely do for critically ill patients has come under question for patients with COVID-19. I think based on some of the feedback that I got beforehand and the time limitations, I wanted to focus a lot on how we've been treating patients with acute respiratory failure, as that's the predominant problem that we had. I'd like to talk a little bit about kind of what we think about as goals when we're treating patients who come in with respiratory failure. Think about what different treatments we've been using, and try to highlight some of the newer or controversial areas. And then we'll talk a little bit about at the end about the coagulopathy that we see with it. And I think, as you know, Dr. Yerlu said, it's definitely something that we're thinking about commonly. I'm happy to answer any other questions, but I wanted to be respectful of the time that we have. For us in Boston here, you know, we started preparations for COVID-19 in early January. In Massachusetts, we had the first positive case on February 1st, where there was a student who returned from Wuhan, China, who was positive. He was not hospitalized, but really the seminal event for us was the international leadership conference that was held by the pharmaceutical company Biogen in a downtown Boston hospital at the end of February. There were, in attendance there were leaders from Europe who had attended, and a couple of days later, people who were at the conference started to present to hospitals and were positive, and there was a super spreader event from which there were 100 cases directly related to that conference. So it really, after that, the actual clinical the clinical lay of the land changed significantly in Boston at that point. What I'm showing on this slide here is this is some inpatient, our inpatient midnight census at Brigham and Women's Hospital, which is a 700-bed hospital in Boston. This shows in the dark blue line what the midnight census of COVID positive patients was. It does not show the patients who are under investigation at this time. What you can see in the gray is the non-ICU population per day, and then shown in brown is the ICU population. Again, this shows only the confirmed positive patients. We have at baseline, just to give you a sense, 20 medical ICU beds in the hospital. During the time of COVID, we moved all of the COVID patients actually to a different ICU, and that ICU census, we got up to be over 100 patients of COVID positives or patients under investigation. One of the things when you look at the ratio of what we saw of what we've seen of ICU versus non-ICU, we know that in the literature that approximately 20% of the patients who are COVID positive require hospitalization, and somewhere about a quarter to a third of those end up in one of our in an ICU. The data here with the relative ratio really reflects the fact that we're a tertiary care hospital and we're taking a lot of referrals, but also the fact that the ICU patients, their length of stay is significantly longer than the floor patients. On this slide here, I just tried to gather a little bit of information around what are the clinical characteristics that we're seeing across the world in patients who are critically ill. And again, the predominant problem that brings people into the ICU is acute respiratory failure. You can see here the range from 71 to 99% of patients with that problem. But as everyone knows, these patients are incredibly complex and sick otherwise, with 2/3 to 3/4 requiring vasopressors, renal failure being very common, with up to 30% of patients requiring initiation of renal replacement therapy. A vast majority of patients requiring initiation of antibiotics for concern of a concomitant bacterial infection, and the mortality is very variable and high. And I would say all of this mortality data is really incomplete, because at the time of publication of most of these studies, a large percentage of the patients were still in their ICU. So this is really the lower level of mortality that's being reported in many of these studies. Despite the fact that it's predominated by one disease process, the acute respiratory failure, on this slide, I tried to point out that there's a lot of variability in the way people actually treat this. And that's why I think it's really important and interesting for us to discuss it. So again, these patients require, in very large part, some type of ventilatory support. I think you can see a really interesting spread of what percentage of patients actually get invasive mechanical support versus non-invasive support. And I think that really reflects practice differences in different areas of the world as we became more familiar with the disease, and also reflects somewhat what different hospitals can actually provide in their ICU versus out of their ICU. But a large amount of ventilatory support, a wide distribution on the use of high flow of nasal cannula around the world. Again, specifically when you're looking at mechanical ventilatory support, wide variation in the use of non-invasive ventilation. And then some of the earlier studies from China, a very high percentage of use of ECMO for patients. So really different, not one way to treat everybody. When we I think, start out with just some kind of general management guidelines and goals, when patients present with hypoxemia, certainly we aim to try to get their oxygen saturation up to about 92%. We really don't feel that there's any need to drive people significantly higher, and we do often worry about, if we go too high or excessive use of oxygen, about the oxygen toxicity. But in addition to just getting the oxygen up, we want to make sure that people also look comfortable, and we're supporting them to do that. Many of you have seen that many patients will present with complaints of dyspnea, which are or hypoxemia out of proportion to the dyspnea that people are complaining of. The people have termed these people the healthy hypoxemic, but these patients tend to be, even though they're not complaining of a lot of dyspnea, tachypnic, and a certain fraction of them are using a lot of respiratory effort. And what we worry about in those patients, even if we've gotten their SATs up okay, we worry about these patients who are doing excessive work, that they're having wide swings in their intrathoracic pressures, and that in itself could potentially potentiate the lung injury that people have directly related to the virus or to the endothelial injury. And that type of injury with excessive intrathoracic pressure swings sometimes is called, in the literature, referred to PSILI, or patient self-induced lung injury. So we want to make sure that we're supplementing people, not just to get their SATs up, but to try to get them to be comfortable. What are the techniques that we do it? Well, you're all well acquainted with it. We escalate oxygen therapy, and starting with first just a basic nasal cannula, then moving to a Venturi mask and a non-rebreather. And I think we try to use those first because there's some literature that potentially there less aerosolization of virus particles using those techniques. We've started to use prone ventilation in the awake patients, and I wanted to talk just a little bit about that because we've found it to be a useful tool. We've known for 45 years in patients who are mechanically ventilated that being in the prone position improves oxygenation. This is well described. Why is that? Well, I tried to show on the slide here, being supine is actually not a great idea to ventilate, not a great position to ventilate. One of the major issues is that you can see on the top diagram on the left, that in the supine position, the diaphragm it naturally pushes backwards, and the heart also compresses the dorsal basal sections of the lung, which increases the amount of atelectasis in those dorsal areas. When you have that, with the atelectasis, you have areas of VQ mismatch and shunting, both contributing to hypoxemia. In addition, there's some overinflation of the ventral areas of the lung. Separate from that, it's also a great position for patients to aspirate. So if you have somebody with a marginal respiratory status, supine may not be the best way for them to be long-term. You reverse all of this when you're in the prone position, and that's shown in the figure on the left on the bottom. Again, it reverses what we've talked about. Therefore, you have improved aeration, improved ventilation perfusion matching, reduction of shunting, causing improved oxygenation. And in the prone position, in a disease like COVID-19, where there are increased respiratory secretions, it's actually the way to improve secretion clearance. Interestingly, despite the fact that we've used this in mechanically ventilated patients now routinely for 8 years, there's not a lot of data before COVID-19 about using awake prone ventilation. I could find one study from 5 years ago where they collected 15 patients of data over 5 years. It just shows the P to F ratio significantly improving in patients when they went from the supine to the prone position. and then how it decreased again when they were brought back against supine. But early on in COVID-19 out of China, there were reports that they started to use supine positioning in patients who were awake and could self-prone. Not a lot of data accompanied their descriptions of using it. There was a study in an emergency medicine journal where they looked at now 50 patients, 50 consecutive patients showing an improvement in oxygenation when people were put in the prone position. When people presented to triage, their SATs were 80%. With supplemental oxygen, they got up to a mean of 84, but with proning, they were up to 94%. Of these 50 patients that they reported on, 13 went on to being intubated. But it's and again, it's really just observational. It's not clear how many of the patients who avoided intubation with this strategy, but I think anecdotally, it's important that it's likely that we've seen patients who early on we would have intubated, but by using prone ventilation, we've definitely been able to avoid intubation. And again, this is just one slide that was in the Canadian Journal of Anesthesia showing the significant or the improvements in the P to F ratio at the time with the red arrows whenever the patient was put into the self-prone position. So we have been now encouraging use of self-proning. We're trying to study it and as well as many other people to get some really good prospective data on it. Next, I wanted to turn attention to high-flow nasal cannula. I will say at the outset of all this, of our preparations for COVID-19, we very much discouraged the use of high-flow nasal cannula, and I think we've changed over the last several weeks with experience with patients. So the upside to using high-flow nasal cannula is that it is well established in the pre-COVID ARDS literature that use of high-flow nasal cannula leads to improved outcomes, less people who need to go on the ventilator. So that was one of the reasons why we really wanted to be able to use this. In a resource-constrained environment, such as we see with COVID-19, also having the option of high-flow nasal cannula is great to save the number of mechanical ventilators that you would need to support people who have respiratory failure. And going along with that, you'd save yourself the medications that you need for sedation, neuromuscular blockade. So there were a lot of reasons why we wanted to try to do it. The biggest downside and the concern early on was the concern about aerosolization with use of high-flow nasal cannula, particularly patients who are on high-flow nasal cannula and cough. Even there's reports about how to mitigate this by putting a surgical mask over people. But when we weren't really sure what the healthcare worker transmission was going to be, how effective our PPE was, we did not recommend use of this, and we're not using it. The other potential downside, there are some reports that there are certain areas that were resource limited by the amount of supplemental oxygen, and you go through a lot with high-flow nasal cannula. But we have actually significantly changed in our thought, as I said, over the past several weeks. We are comforted by the very low transmission rate in the healthcare workers in our hospital with proper PPE. So now for patients who require higher levels of oxygen support, if they're not sick enough that they need to go directly to be intubated, then after an interdisciplinary discussion, we will use high-flow nasal cannula. It is required that the patients remain on full enhanced respiratory precautions with full PPE, and that we always try to use mitigation interventions like a surgical mask over, or there are some other innovative experimental interventions to try to mitigate aerosolization that we have been and will continue to be involved with to see if that minimizes dispersion. But now it is something that we are routinely using. I think CPAP or non-invasive ventilation is something that we don't routinely use in support of these patients. And I think that's driven mostly by the fact that even for patients pre-COVID with acute hypoxemic respiratory failure, there's not a lot of data, or there's really no good data that shows that improves outcomes. There was also the secondary concern again about aerosolization, but it's more driven by the fact that there's no data to support for hypoxemic respiratory failure. We will, however, in very select cases use non-invasive ventilation, and it's only in patients if they were COVID negative, we have data that it improves. So the two classic populations of patients, we have COVID positive patients who are having an exacerbation of obstructive airway disease, who we will support for a period of time with non-invasive ventilation. Or if we think someone is COVID positive, but their volume overloaded, we will use non-invasive ventilation in those cases to try to diurese them and avoid intubating them. So why don't we next turn to a little bit about what our thoughts are on ventilator management in COVID ARDS, and sometimes in the literature people refer to this as CARDS. So, in Italy, very early on in their overwhelming experience, there were reports in the literature that the ARDS that was seen there is different from our usual ARDS, and we should think about it and not treat it the same way. What led to that was really very early small reports, and I've shown one here. This is one out of Italy, but by a very well-respected group, where they looked at 16 patients and they looked at what was the respiratory system compliance, right? So what we're referring to is, what's the change in volume per centimeter water of pressure that you get when someone's on the ventilator. And what you can see here, in the way you measure this, you can do this easily by doing an end inspiratory pause on somebody, measure what the plateau pressure, calculate what the compliance is. And what they were reporting in this a small group is that these patients who had low P to F ratios had compliance of 50 or above, which is much different than you would expect in typical patients with ARDS, which would be closer to the kind of the 30 range, 30 to 40 range. What they postulated is that these two different types of lung injury, type L or type H, and they acknowledge that people probably are on a spectrum, but the type L, with the L standing for low, is that these people had low elastance, which is the inverse of compliance. So they would have a higher compliance. They would not have a lot of edema and alveolar damage throughout the whole lung, so the weight of the lung would be low. And importantly, if you applied PEEP to these patients, that you probably were going to hurt them because you would overdistend good areas of the lung. So you would not have a lot of lung recruitability. But they acknowledged that as patients remained sick with COVID-19, they transitioned more to this type H, which is what we routinely see, where people have low compliance, heavy lungs, and you need to recruit them to open up those alveoli that are collapsed. This is a separate paper where they showed repeat CT scan images from one patient who, this is early on in their course, when their P to F, with a P to F ratio of low, which was 95, but you can see the chest CT scan A with mostly really good aeration of the lungs. And then this is the same patient 7 days late. In the in time A, they were spontaneously breathing. But this is now in the CT scan B. This is after 7 days, and you can see how much different it really looks, despite the fact that the P to F ratio wasn't much different. And then shown on the far right, they show the Hounsfield units that are associated with that. So raising the question, is the lung injury different? And again, it is potentially the difference related to the fact that not only is the virus causing inflammation in the alveoli, but is it causing direct endothelial damage that somehow is causing this difference in what we're seeing? I'm not convinced, however, how much different this really is from the routine ARDS that we see. And here's another study of 66 patients. These are from Boston at Mass General and Beth Israel Deaconess Hospital, which shows some respiratory mechanics numbers in these 66 patients over the first 5 days of their illness and mechanical ventilation. And you can see the spread that the majority of these patients actually do have P to F ratios, plateau pressures, and a reduced compliance, which is very similar to what we see in our pre-COVID ARDS patients. So I think it's certainly food for thought as we ventilate patients, and we do keep in mind. But I think that part of what people had seen early on in the experience is related to the fact that we were intubating patients based on concerns out of China and Italy about rapid decompensation, that we were probably intubating them much earlier than we used to. So their lung injury had just not progressed as much as we routinely were seeing in patients with ARDS. Again, because we weren't doing things like the high flow nasal cannula, we were seeing people significantly earlier that may have led to some of those initial cases where people had much different lung compliance. So what do we think is important? We certainly want to continue to minimize any volume trauma, and we do that by continuing low tidal volume protective ventilation. We think that you need to be thoughtful of PEEP, but what we do routinely for patients as they're being, when we first start them, we use the low PEEP to FiO2 table for our initial settings. And if somebody has a BMI which is very high, above 35 to 40, then we'll use a higher tidal volume, a higher PEEP, the higher PEEP to FiO2 table to help try to minimize any atelectasis, which could be related to body habitus. But once we've got those initial settings, we encourage people to be thoughtful, and you can try to titrate the PEEP to optimize compliance and oxygenation. But we think starting from the PEEP FiO2 table is fine. We have used a lot of prone ventilation. And just to highlight again with prone ventilation, it's not just the improvement in oxygenation that the reason why we use prone ventilation. I showed this slide like this earlier, but I want to just highlight for the patients who are mechanically ventilated, when you're in the prone position, there's much more homogeneity of the size of the alveoli. And because there's more homogeneity, when you impart a particular PEEP or a tidal volume, it's much more evenly distributed so that you don't cause over-distension or under-distension. So we address with this two important types of ventilator-induced lung injury. Volutrauma is thought to be less in the prone position, as well as atelectotrauma, trauma caused by the repetitive opening and closing of the alveoli. So we think it's that benefit, not the improvement in oxygenation, which led to the results in the PROCEVA trial, which is now 8 years old, a multi-center trial, where very importantly, in patients who had P to F ratios less than 150, they used prone ventilation early and long. So they had a proning dose of 16 hours. There's a lot of earlier data that if you start proning later after 48 hours, or you don't do it long enough, you won't see the benefits that they saw here with the significant reduction in mortality at both 30 and 90 days. So we've proned, in our ICU, about 85% of the patients who have come in have required mechanical ventilation, and about close to 50% of those have had proning as part of their management. To help support it, we've created proning teams that can help develop expertise around doing this technique. We think it's also very important to judiciously use neuromuscular blockade only in patients, but we try to limit that to patients who are asynchronous. Inhaled pulmonary vasodilators are really only for patients as a rescue therapy. If you're continuing to have trouble with hypoxemia, we don't, there's not a lot of good mortality data. And if someone is really getting sicker, then we consult our ECMO team. And I think we've had now, I believe, 9 patients who have gone on ECMO as a rescue therapy. So that's kind of our algorithm, the way we escalate care on mechanical ventilation. I said in the last few minutes, I did want to touch base about the significant coagulopathy that we've seen as part of the constellation of critical illness in patients with COVID. Dr. Irlu mentioned that there's a lot of interest in and work around this. And many studies coming out weekly about this. The major issue, coagulopathy that we see is the DIC. It's thought to be triggered by the pro-inflammatory state caused by the lung injury, as well as potentially contributions from direct endothelial injury. It gets manifest itself by both microthrombus as well as larger venous and arterial clots, which we see clinically, but the microthrombus has been now well described in several autopsy studies. The presence of DIC has been associated with mortality, again, Dr. Irlu showed a recent study, but if you look for a venous clot in these patients, you will find it. And as you see, this was an earlier study before the one that just came out with the repeat screening. But you're finding a clot in 70–80% of the patients is impressive and scary. What are we locally doing right now? So we think it's very clear that anybody who is admitted to the ICU with COVID-19 needs to get VTE prophylaxis. Many of the earlier studies looking at the rate of clot, just because of the hospitals were overwhelmed, the rate of patients getting proper VTE prophylaxis was low. Because we were able to prepare for it, we found that that close to 100% of our patients were getting standard VTE prophylaxis, but we found that the incidence of clinically apparent clot, not routine surveillance, was very high at our institution. So we actually increased the baseline prophylaxis dose to BID dosing for our patients. That's not universally endorsed, but we have been routinely doing it. We have been doing it. We prefer to use low molecular weight heparin as opposed to unfractionated heparin. We don't routinely use DOACs. We don't think that there's any indication for both pharmacologic and mechanical prophylaxis. And I think whenever we get patients who, despite this, get ongoing clots, it always raises the question of whether or not we should further anticoagulate people. And I think there's a lot of discussion about should all patients who reach the level of critical illness get therapeutically anticoagulated. This is raised by a lot of small studies and retrospective studies. I raised, I've just noted here the one out of Mount Sinai in New York, where they looked at 2,700 hospitalized patients, 28% who were just otherwise on systemic anticoagulation. If you looked at the mortality overall, there wasn't a significant difference between people who weren't or weren't on anticoagulation. But I think everybody in the critical care community was, had their eyes opened by the fact that they reported in the patients a significant difference from 29% to 63% among patients who were on mechanical ventilation. Certainly the downside to this is the bleeding, this slide is incorrect. The bleeding was 3% in people who were anticoagulated and 1.9% in people who weren't. So I think our take on it is that it's really interesting finding in retrospective studies, but that we don't think that patients, that there's any evidence that patients would benefit by routine therapeutic anticoagulation. So we do not routinely do it. We are, but we do think it's important to study it. And so we have a study which is going to be starting up just this week at the Brigham, looking at this question. This is just graphically showing the survival curves between all patients and the difference that you can see between the two populations, the anticoagulated and not, being driven by the 395 patients who are on mechanical ventilation. So I'll stop here. But just say, I think major points are when you take care of somebody like this, you want to use all of the tools at your disposal to maintain SATs of about 92%. Make sure you're supporting patients to try to address excessive work of breathing. Before people are intubated, consider using prone ventilation. We think high-flow nasal cannula is now safe and established. It should be used to try to avoid invasive mechanical ventilation. You could use non-invasive if somebody has a condition that otherwise has been proven benefit, but we wouldn't routinely do that. And if you have to intubate your patients, continue low tidal volume ventilation, prone ventilation, and neuromuscular blockade like we routinely do with people with respiratory failure. I think regarding anticoagulation, it's hard for us to say that, as I said, we increase our dose of prophylaxis, but I think, we should shortly have, I think, more study, more data on whether or not that's the right thing to do. And we don't encourage anyone to routinely fully anticoagulate anybody until there's more data. Again, thank you for this opportunity.
Thank you so much, Dr. Massaro. There's a lot here. There's a lot of layers and a lot of questions being generated by your talk. I know you're very busy. I wonder if you have about an extra 10 minutes, would you be willing to go over just a few minutes?
Absolutely.
Okay, well, thank you. And let me just start by saying not only is Dr. Massaro an attending physician, but he's the medical director of the medical ICU, the medical director of the special pathogens ICU, and also serving on the incident command team as the co-lead for the critical care branch in the operations section. I'm sorry, I neglected to add that before. And that just highlights, I think, how valuable your time is and how fortunate we are to have you join us. So thanks again. The first question, we talked a lot about proning today. At Brigham and Women's or in the wider world of critical care literature, has there been identified an optimal ratio of front to back time spent for proning in a given day? And could you comment at all on early proning in the emergency department?
Yeah, so I'll answer the proning, the time that somebody is proned for patients who are mechanically ventilated is thought to be actually quite important. There were trials starting in the 90s which didn't show any significant benefit from proning, despite the fact that people's oxygenation improved. And it's thought to be related to two things. One is that those trials all enrolled patients who were further in the course of their illness. They would allow people sometimes up to 7 days of respiratory failure before they started to prone. And the proning dose was as low as 3-4 hours. For the patients who are mechanically ventilated, we think it's really important to start as soon as possible once the P to F ratio is less than 150, ideally before 36 hours, in that the people should stay in the prone position for at least 16 hours. There are some people who advocate longer, but that there's not a strong data for that. And in the emergency room, for patients who are not intubated, absolutely, we think there's nowhere near as strong data, and the proning dose there is really unclear. What we're advocating for people to do is to who are not intubated is to try to do 2 hours in the prone position, 2 hours in the right lateral position, go supine for 2 hours, and continue that rotation. And if people are able to tolerate it when they go to sleep, to try to sleep in the prone position. I will say there are also some pillows that are coming out that I see advertised, which we've never used, which try to make it easier for a patient to stay in the prone position.
Thank you. And then just to highlight what you said about outside of high flow nasal cannula for non-invasive positive pressure ventilation, before COVID, a lot of us, especially in the EDs, were reaching for BiPAP left and right. It sounds like you're being very selective about the application of non-invasive positive pressure ventilation to those folks who we might have reached for in the past, the folks who are volume overloaded, maybe the folks with obstructive airway disease. But other than that, you're going from high flow nasal cannula and moving on to intubation.
Yes, we do. When we initially wrote our guidelines, based on reports that were coming out of China and early out of Italy, I think we initially said call anesthesia when you're on more than 6 liters of nasal cannula to talk about intubation. I think we learned very quickly that was being much too conservative, and that we were intubating people unnecessarily. So that's so I think we've moved a lot with that, but we still don't feel you should stop. That if you're failing high flow nasal cannula and you don't have any of the conditions that you just mentioned, we will go ahead to intubate at that point.
Thank you. And if you wouldn't mind just the stop sharing of your screen, we'll get a better gallery view of all the participants on the assigned panelists. Thank you. Many of us, especially in the Southwest, some in the Northwest, work at higher elevations. Here at Fort Defiance, we're at close to 7,000 feet. So is Gallup, where John Earlow is. We use, I'll speak for Fort Defiance alone, an room air oxygen saturation of 90 as a reasonable cutoff. Do you have any comments for interpretation of oxygen saturations, I guess, alone, because we really should be taking in the entire clinical picture, not just that number. But do you have any just general comments on how we might adapt the sea level recommendations for those of us working at moderate or high elevation?
Yeah, a great point. I think we've even separate from COVID become more comfortable with patients being permissively. We've always had permissive hypercapnia, but now allowing people to be permissively hypoxemic. There's still, I think, a lot of work to do around this, but we are comfortable for a lot of our patients. Even a lot, if they look comfortable and their SATs are 88%, I think less than 88%, we do start to worry about it. But while we target 92-ish, I think we certainly would tolerate. I think at higher elevations it makes sense to tolerate 90 without any problem.
Great, thank you. And I think we had a question from Chin Lee from Dr. Bornstein, if we're able to get Dr. Bornstein on the screen.
Hi, yes. Thanks so much for taking my question, and thanks so much for your presentation, Dr. Massaro. We'll say we've been closely following your protocols since the onset of COVID out here, and we really appreciate all your hard work. Our question is with regards to high flow nasal cannula and choosing criteria for intubation. We were sort of early adopters of high flow here, primarily due to our staffing and inability to take care of intubated patients for long periods of time. So we have many patients. We have 10 high flow machines for a COVID ward of about 26 patients, and we typically are running 7 or 8 patients at a time on high flow. And I think one of the hard or challenges that we face is when to determine that turning point of those patients who should be intubated. We reviewed our numbers just from our first 90 hospitalized patients, and about 30% of the high flow patients are able to be ultimately weaned off of high flow and avoid intubation altogether, whereas 70% are ultimately intubated. And I was wondering if you could speak to other criteria or recommendations on when to intubate the high flow patients. Thank you.
Yeah, no, well, so thank you, and thank you for all the work out there. You know, I will say we could learn from you, I think, about, you know, because you have more experience with the high flow. I think the route, you know, the things that we always even before would use for teaching is that, you know, high flow is great to try to avoid intubation, but if you need intubation, then you need to be intubated, right? So I think we would look for other, you know, things, particularly like, you know, what somebody's respiratory rate was, and really how hard they look like they're breathing. I think personally, if I thought that the person was looked very comfortable and their sats were, you know, 92% on the high flow, I would be fine letting, you know, continuing with that. But if it looked like the person was really working hard using accessory muscles, even if they were maintaining their sats okay, I would worry about, am I propagating some type of lung injury, and at that point try to intubate them. And again, I think that's, you know, that's the type of a person who you know, there's something that seems appealing about trying them on, you know, non-invasive ventilation, but I think there's really no data there is no data that improves people, and there is data that it actually may worsen, and if they need to be intubated, they need to be intubated. So I think that's what I would say is, you know, looking at what their respiratory rate is and how hard they're working is really the other best parameters.
Great, thank you.
Thank you. Great question. And there was another question that had come up in the Q&A about, this is shifting back to the clinical update from Dr. Irlu about early convalescent plasma therapy. And Dr. Irlu, I didn't know if you had any comments about the perceived benefit of early convalescent plasma therapy versus saving it for severe patients, or Dr. Massaro as well. Would love to hear your thoughts and what you all are doing with convalescent plasma.
So we're not using it in Gallup, but we are actually working with Johns Hopkins to come up with a research protocol for using convalescent plasma on Navajo for persons who are exposed to COVID-19 and for persons who have mild COVID disease going home from the emergency department. So maybe we'll have an answer for you in several months. We'll see.
Yeah, I think it's really intriguing therapy. We've not used it at all at the Brigham either. Our blood bank was quite adamant that they would only wanted to use it in the setting of a clinical trial, which we have one starting up at the Brigham that also is supposed to be starting up this week, where people will be randomized to convalescent plasma versus FFP. And what we could get available locally from, in one of their concerns was that what we could get from convalescent plasma from the Red Cross was not evaluated for any titers of neutralizing antibodies. And what they had said, and again, I don't know the primary data, but they had said up to 30% of that population of the patients who were getting it actually did not have any neutralizing antibodies in it. So I think that gave everybody pause, and so that's why we haven't we've not done it all yet. I'm also interested, Dr. Iralu, like, in thoughts are, as more data comes out that after 8-9 days you can't get any viable virus back from patients, even though their swabs remain positive. If you're not giving it up front like you're planning on doing it, what's the postulated mechanism by which it works?
Yes, I don't know the answer to that. That's why I looking at that paper that was published last night makes me say, once they're in the intensive care unit, it's no longer an infectious disease. It's a cytokine storm, and it's a critical care illness. So it's kind of an interesting phenomenon, that what happens around that 8th or 9th day when the virus disappears from the nasopharynx, but the damage is ongoing. It's more an endotheliitis at that point.
Yeah, agreed.
And which, of course, raises, I think, a lot of questions about the potential role of biologic agents and a whole other host of potential future topics for discussion. We're over time now, about 10 minutes. We could obviously continue this discussion, but want to be respectful of everyone's time, and really want to extend a special thanks to our feature presenter today, Dr. Anthony Massaro, who undoubtedly has any number of several administrative tasks, if not clinical, to get back to. But thank you, Dr. Massaro, for taking time out of your day to join us, and all the best to you and your colleagues at the Brigham. And again, thanks to IHS headquarters for allowing us to have this time supporting these sessions. Dr. McCollum, thanks for the update. To the entire ECHO team for another excellent, well-run, well-organized session. Thank you for keeping these going every week. And to each of you for all the work you're doing at your individual sites. Everybody, please stay well, stay healthy. And I do want to send out a quick teaser for the next couple weeks. Next week, we'll be discussing pediatric vasculitis cases emerging with COVID-19. So please join us for that session. And the following week on June 18th, we're going to be looking at strategies for reintroducing ambulatory care services. Rather, all services will be rejoined by some of the leadership team at Brigham and Women's Hospital again. So please join us for that on June 18th. In the meantime, stay well, stay healthy, and we look forward to seeing you next week. Thank you all.